welcome to the Stronger After Stroke podcast. I'm your host, Rosa Hart, the stroke nurse navigator here at Norton Healthcare. And today joining me is our medical director, Dr. Bryan Eckerle. Thank you so much for taking the time to answer these important questions that our stroke survivors and their families have.
Of course. Thank you for inviting me.
Yeah, definitely. Usually, Dr. Eckerle sees patients and their families in the hospital, not necessarily once they get home at this point. And so I really want you to hear it kind of from the horse's mouth of why these medications get started in the first place and what all goes into making those decisions. So the first one is many stroke survivors leave the hospital with a lot of new medications. Some of them have never been on any medications before ever. Can you start by explaining why these are so critical to recovery and future stroke prevention?
Sure. So we do make lots of medication changes, adjustments, sometimes start new medicines in the hospital. I would say by and large, almost all of those medications are focused on what we call secondary prevention. So secondary prevention means preventing another stroke or, in the cardiac world, another heart attack in someone who has already had a stroke or a heart attack. Primary prevention is taking medication to stay healthy in people who haven't suffered stroke, heart attack, or other cardiovascular event. Secondary prevention is a little different because we're managing folks who are higher risk because they've already had a stroke before. And so the testing that we do, we do lots of really exciting, really amazing things in the first hour or two people arrive. Sometimes we take blood clots out of arteries, we give clot busting medications. After those interventions are done, hospital days 2, 3, 4, 5, and on, the testing that we're doing and the medications that we're prescribing are almost entirely focused on preventing another stroke. And so we take pictures of arteries, we take pictures of the heart, we check blood work for cholesterol and for blood sugar. And the medications that we change and start in the hospital are generally focused on preventing more problems in the future. We think that about 80% of strokes are preventable with a combination of lifestyle modification, and by that I mean diet and exercise and avoiding cigarette smoking and avoiding heavy alcohol use, among other things, and then medications. So, and we'll talk, I know, more about these in specifics, but cholesterol medicines and blood sugar medicines and blood pressure medicines, and then the blood thinners or the anticoagulant, antithrombotic medications. So we're really, most of our efforts after that first day are focused on preventing more problems.
So all of these medications that got added, like if they're looking at it and they have 5 new medicines, each one of those was added for a reason, right?
Yes.
It wasn't just like, let's throw this at it and see if it'll work.
Correct. We have troves of data and literature about different risk factors for stroke and what the most appropriate strategies are in each of those instances. And so we're tailoring medication regimens specifically for individual patients and their risk factors to try to keep them healthy.
Which is why it may look different from one person
Correct.
to another, which is why I really wanted us to have this conversation where people can get some more context, because you may have someone who has a stroke, but their husband or wife had a heart attack and they're on a different medication that does something similar, and they don't understand why they need to be on something different. Or they're filling their parents' medication and they're like, why is this different than what our uncle is taking? So it's good to know that all those are for a reason.
Mm-hmm.
And let's start with the antiplatelets, because I think there's a lot of easily terminology confusion there, because people will call those blood thinners, and that's not quite what they are. So what role do antiplatelet drugs play in stroke recovery, and how do they prevent another stroke?
Yeah, so antiplatelet medications, the most common is aspirin. There are others, clopidogrel, ticagrelor, dipridamol. There are a handful. Those work by preventing platelet activation and platelet aggregation. So that's one of the first steps in the formation of a blood clot. We tell people, and generally we think that strokes are caused by blockages in arteries in the head, the same way that heart attacks are caused by blockages in the heart. And our job is to figure out why the blockage happened, where it came from, and then how to prevent it. So antiplatelet medications fall under the broad category of antithrombotics, but not of anticoagulants. And so there is some nomenclature that can get a little bit confusing. Antithrombotics are any medication that try to prevent blood clot formation. Antiplatelets work on the platelet part of the coagulation process, and anticoagulants work on a slightly different process. So antiplatelet medications are meant to prevent that first step in the formation of a blood clot, where platelets activate and aggregate and clump up to start the formation of a clot.
And are there situations where one antiplatelet like clopidogrel is preferred over something like aspirin?
Yes and no. So there are reams and reams of trials and studies and literature and science about which antiplatelet medications are preferred in which settings. At the end of the day, for the most part, aspirin and clopidogrel are considered equivalent. There was a trial that compared aspirin to clopidogrel that showed no meaningful difference in stroke recurrence rates.
Wow.
And so there are instances where side effect profiles or other interactions with other medications might push us one way or the other. But in terms of the absolute benefit, in terms of stroke prevention, we think aspirin and clopidogrel are essentially equivalent.
So, what side effects would those be that would help you decide, well, aspirin's very, generically affordable, it's over the counter. So, why would someone need to take clopidogrel and not just take readily available aspirin?
The most common reason to avoid aspirin is people who have stomach problems, ulcers, and peptic ulcer disease in the stomach or the small intestine. Aspirin can aggravate those problems. Any blood thinner can cause a bleeding ulcer to bleed more, but aspirin actually can affect the lining of the stomach more than clopidogrel can.
Causing the bleed to start in the first place, whereas all of them will cause it to continue bleeding.
Correct. And then clopidogrel has some, coincidentally, maybe interaction with medicines for reflux. So some of the proton pump inhibitors like omeprazole and esomeprazole, those can interact with clopidogrel and make it not as effective. And so in patients who are on proton pump inhibitor medications, we might lean more towards aspirin.
See, there's a reason for every single decision.
And if you don't know the reason, you ask someone, and we will tell you.
That's right. There's no dumb question except the question that you don't ask, right?
Correct.
I really appreciate that attitude around here. It is helpful for learning. So, what side effects should people watch for when they're on aspirin and Plavix? Obviously, we said bleeding, but what could that look like?
Yeah, it's mostly bleeding, and most of the bleeding is really not problematic medically. So patients bruise more easily. If a man is shaving and nicks his face, he might notice that it takes a little bit longer to stop bleeding. Those sorts of things. Bleeding is cosmetically challenging for people. But we always try to weigh risks versus benefits, and we think that stroke prevention is a good enough benefit to tolerate some minor, less fun but not dangerous side effects. The things to worry more about is if you notice blood in the stool or blood in the urine or you're coughing blood, anything that's blood where it really isn't supposed to be,
Especially
would
bright red, right?
Yeah, that would warrant a call to the doctor, if not a visit to the emergency room.
Yeah, definitely. And then that brings us to anticoagulants, which are really what we mean when we say blood thinners.
Yes.
And that could include warfarin, apixaban, rivaroxaban, so-called Xarelto, or Eliquis. So for patients with atrial fibrillation or heart rhythm issues, anticoagulants are often prescribed. And how are those different from antiplatelets?
So the anticoagulant medications act on the what's called the coagulation cascade. There are a variety of proteins that are constantly active in the bloodstream that balance the clotting system. So the body is always producing and then dissolving tiny little blood clots. And the anticoagulant medications sort of tip the balance of that system towards dissolving blood clots. So the idea is that they prevent formation of clots that may not be as directly related to platelet activity. We use those mostly in the setting of heart problems. And heart problems are not always directly correlated with cholesterol plaque or atherosclerosis.
And by
so
heart problems, you mean atrial fibrillation?
most commonly atrial fibrillation, sometimes what we call congestive heart failure, where the heart muscle gets weak. Patients who have artificial heart valves, we sometimes start blood thinners. But we know from, again, randomized controlled trial data that in the setting of atrial fibrillation, aspirin does reduce the risk of stroke a bit, but the blood thinners or the anticoagulants like warfarin and apixaban and rivaroxaban reduce the risk of stroke by quite a bit more. And so in patients who have any of a number of heart problems, we tend to lean towards the anticoagulants instead of the antiplatelets.
And that's why sometimes people might get discharged on the antiplatelets like Plavix and aspirin and go home and wear a heart monitor.
Yep.
And then if the heart monitor shows that they have atrial fibrillation, then you might want to change that
Correct.
to a blood thinner.
Correct. So it's about 25 or 30% of patients that we take care of in the hospital have a stroke without a known cause. And that clinical syndrome goes by a few different names. The older name for that is cryptogenic stroke.
Which means we don't know.
Which means we see you have a stroke, but we're not sure why. And despite an adequate diagnostic assessment, right? And then the newer term for that is embolic stroke of undetermined source. And those are close to the same definition. There are some subtle differences. And in patients who have cryptogenic stroke or ESIS type stroke, we will often send them with heart monitors for that exact reason. We're looking to see if you have atrial fibrillation. Atrial fibrillation is tricky. It can come and go. It doesn't have to be present at all times. And so one might have had a stroke that was a result of atrial fibrillation, but not be an atrial fib in the hospital. And so we monitor people with one of a number of rhythm monitoring strategies over time. I tell people it's sort of like a stakeout with the police. You're just watching to see what's happening because you don't know when danger might strike, right? So you watch and you see. And if someone has a cryptogenic stroke and then a week later they have atrial fibrillation on their heart monitor, they no longer have a cryptogenic stroke. We now know that the cause of the stroke is the heart rhythm, and we change those patients, generally speaking, from antiplatelet medicines to anticoagulant medications.
Right. And I have had some patients say, well, why don't you just put me on the blood thinner to begin with? Why fool with all this, like wearing monitors stuff? But it's really because the bleeding risk is higher with anticoagulants, right?
Yeah, and that's a great question. And it's a question that's been investigated again with a specific randomized controlled trial. So they took patients who had cryptogenic strokes and they randomized them. And so what I mean by that is you take 1,000 patients who have a problem and half of them get one medicine, half of them get the other medicine. The patients don't know who is who, the doctors don't know who is who, and then you watch and you see, because that is the most robust way to isolate the difference in the actual treatment to tell the difference between two treatments. So that's sort of the gold standard of medical science, is the randomized control trial. So there was a randomized control trial where they took patients for that exact question. They said, well, why don't we just skip the monitor? It's a hassle. It takes time. It's uncomfortable. Why don't we just go straight to an anticoagulant medication? And that trial showed that we didn't see a benefit in that group. So
only an increased risk of bleeding.
Correct. And so if you don't know someone has atrial fibrillation, it really is not wise to jump straight to anticoagulant medications.
It really is trying to do the safest thing for the patient with the information we have on hand.
Yeah, and again, it's as individualized as we can make it. So we don't know who among the group of folks with cryptogenic stroke will ultimately prove to have AFib. There's no way to know without looking. So we look.
Yeah, that's great.
Yeah.
And then we'll go to statins. So statins are cholesterol medications, and there are some cholesterol-lowering medications that are not in the statin family. There's just a lot of statins, so I'll bring that up.
Yep.
And that's usually their first line of treating high cholesterol. They're sometimes surprising to patients who don't have high cholesterol. So why are those people getting prescribed statins after a stroke?
Sure. So the statin story sort of comes from, again, a randomized control trial called Sparkle. They took patients who had LDL cholesterols between 100 and 190, and they randomized them to 80 milligrams of atorvastatin, which goes by the brand name Lipitor, versus placebo. And they followed them for 5 years, average, to assess for recurrent stroke risk. So the patients who got atorvastatin or Lipitor at the 80 milligram dose had a lower risk of stroke in that follow-up period than those who didn't. That benefit was seen irrespective of the starting cholesterol level. So patients whose LDL cholesterol was 101 had the same benefit as patients whose cholesterol was towards the higher end. And so we infer from that information that statins probably have benefit in stroke risk reduction beyond just lowering cholesterol numbers. We know that elevated LDL or bad cholesterol is associated with stroke and heart attack. And so lowering those numbers is good, but even in people whose LDL cholesterol is already nice, we like to use high intensity statins either way because of that benefit that was seen across the group in the Sparkle study. There are, as you say, lots of different versions of statin medications. As a general rule, we try to use high intensity statins. So there are 4 high intensity statin doses, and that's 80 milligrams of atorvastatin, 40 milligrams of atorvastatin, 40 milligrams of rosuvastatin, which is called Crestor, or 20 milligrams of rosuvastatin. So there are other statins like pravastatin and simvastatin. And when patients are on those medications and they come in with a stroke, if there's not a compelling reason not to do so, we will switch them from a low or medium intensity to a high intensity statin. And that is, again, based on the Sparkle trial data.
Well, that's a fun sounding trial. I do like the
Yeah,
name, I must say.
It's very fancy. The fancier the name, the more people will pay attention.
That's how I feel.
Yeah, I think
I'm
that's
trying to
true.
make stroke look really fancy so
Uh-huh.
people will pay attention because it is a big deal.
Yeah.
And I mean, every 40 seconds, somebody in the United States alone has a stroke. And it's the number 1 leading cause of disability worldwide. So we better learn about it.
Yep.
So this is so important.
And
We're
that-
only like halfway through here, but
And that risk reduction was small, but definitely meaningful. So again, if we think back to that 80% overall risk reduction, right? That's some from treating blood pressure. That's some from treating cholesterol. That's some from diet. And so there are all these things that we know are real drivers of reduced risk. And so anywhere we can get a little additional benefit, we're going to try to do it.
Right. And you were talking about the effect of statins on people with more normal, quote unquote,
Correct.
levels of cholesterol, where if they went and saw their primary care provider with their cholesterol total being under 200, then they weren't started on a statin because it wasn't necessarily treatable. But the fact that they had a stroke means that that's a new reason.
Yeah.
Not just that lab value by itself.
Correct.
Right?
And that goes back again to that distinction between primary and secondary prevention, right? So not everyone in the country or the world should be taking statin medications because the vast majority of people are not going to have a stroke or a heart attack.
Hallelujah. We just don't meet those
Thank
people
goodness.
as
Correct.
much.
Once you've had a stroke or a heart attack, you're in that secondary prevention world, and we are a lot more aggressive because the benefit is higher. So everything we do, we're weighing risk and benefit. And if the benefit exceeds the risk, we tend to try to do it. That's true when things are both very beneficial and very risky, like brain surgery for stroke.
Yep.
And we do that when things are pretty safe, but a little bit beneficial, because as long as the benefit outweighs the risk, we like when we can to do those things. And so in that secondary prevention world, and people who have had a stroke already, we know their risk of stroke is higher. And so we're going to be more aggressive. And we think we derive more benefit from statin use in that group of people.
Is there evidence showing that it stabilizes the blood vessel wall or reduces inflammation, and that's part of the protective mechanism, not just lowering the amount of LDL floating around in the blood?
There are hypotheses, those are 2 of them, about why else statins might be helpful. There's some really cool research being done now on different imaging modalities, CAT scans and MRIs of the carotid arteries, and looking at different characteristics of cholesterol plaques and trying to learn a little bit more in a little more granular detail which characteristics are more worrisome and how do medications affect those things. I don't know that those have been borne out in RCTs just yet, but that's definitely a consideration, the anti-inflammatory effect and then the plaque stabilization.
Excellent.
Yeah.
And then some people worry about muscle pain or other side effects, like maybe they've taken a statin before and they were experiencing those side effects. How should they talk to their doctor if they experience these?
Yeah, we hear that question a lot, and it's usually in the form of, my neighbor took atorvastatin and he had a terrible time with it and was miserable and had to stop it. And there's some trepidation, and that's understandable. In people who have never been on a statin before, I would say know that there is a risk of muscle problems. Those are almost always reversible from the medication. And so if you develop muscle pains after starting a statin, that would certainly be a reason to talk to your doctor about changing or discontinuing the medication.
Should they wait a year before they talk to their doctor?
No, I would talk to their doctor at the next available. It's not an emergency, but that's something. If I were started on a statin and a week later I developed muscle pain, I would call my doctor.
Or send a MyChart message? Yeah.
In people who have been on a statin before and didn't tolerate it, it gets a little more into the art of medicine and not the science of medicine. There are some statins that we think are better tolerated with respect to muscle pain and others that are less well tolerated. And so it may be an issue of changing from, say, atorvastatin 80 to rosuvastatin 20. If someone has already tried and failed 4 statins because their primary care doctor is on top of it and is doing a great job, I'm probably not going to try a 5th. And in that case, we talk about other strategies for reducing cholesterol. There are some infusion medications that can reduce cholesterol levels. Those haven't been studied specifically in stroke prevention as robustly as statins, but there are some other options for other medications. And then, of course, dietary changes can affect cholesterol levels too.
Yeah, definitely. We always want to encourage people to try to follow the Mediterranean diet and things like that, eating whole food ingredients as much as possible, because that's the best long-term plan.
Yeah, and that's fresh fruits, fresh vegetables, lean proteins, poultry, fish. We sometimes tell people generally we like you to shop on the outside of the grocery store, not the inside of the grocery store. There are some things on the inside of the grocery store you'll want, right? But the fresher, more perishable things are generally speaking going to be better for us. And things that are good for brain health are good for heart health, are good for overall health. And so that's a question that comes up a lot too, diet issues. And it doesn't mean you can never have bacon again. It doesn't mean you can never have a candy bar again. It's moderation, right? And it's trying to, for the most part, stick with produce and lean meats and less processed things and less fried things and fatty things.
Yes, which is hard to do in Kentucky, but it's definitely worth doing for stroke prevention.
It is.
Yeah. That'll take us to blood pressure medications. So high blood pressure is one of the biggest stroke risk factors. How do you decide which blood pressure medication class is right for a patient?
So this is a good question. This is where the partnership that we have with our other team members in the hospital is really important. So when you're in the hospital for a stroke, you'll see a neurologist, but you also see an internist or an internal medicine doctor. You might see a cardiologist. And then, of course, you'll see physical therapy and speech therapy and occupational therapy and respiratory therapy. I don't want to leave anyone out. Nursing, everyone has a hugely important role. The internists generally help us in choosing which blood pressure medication we use. So we know that blood pressure is another one that's a little bit nuanced in the hospital. So this comes up in the first couple of days after a stroke, the blood pressure tends to be on the higher side. And we want that actually, because that's the brain crying for help, right? And so the brain is asking for the blood pressure to be higher to get more blood flow to the sort of border zone around the stroke where there's still some dynamic things happening and
provide that oxygen to the injured area.
Gets extra oxygen, extra glucose to the part of the brain that's in that sort of intermediate zone, right? So for the first few days, we let people have high blood pressure. We want their blood pressure to be a bit higher. After that first 24 to 48 hours, we start to then gently try to reduce the blood pressure, because while in the short term, high blood pressure is okay and helpful probably, in the long term, we know that high blood pressure is probably the leading modifiable risk factor for stroke and heart disease in the country. So the long-term blood pressure goal is generally lower is better, but certainly in that less than 130 over 80 kind of range is where we like blood pressure. How we get there is where we lean on our partners in internal medicine and then in primary care, right? I don't, as a stroke doctor, feel strongly about which blood pressure medicine is better. I just want the blood pressure to get where it needs to be.
In that safe zone.
Yeah. And so that's, there are probably 5 or 6 classes of blood pressure medicines that get used pretty commonly.
Mm-hmm.
When I was learning how to do this a long time ago, we chose medications mostly based on side effect profile and efficacy too, but it's a little bit like dating. You try one, if it works, you stick with it. If it doesn't work, you break up with it and you try something else.
Nice.
And so whichever medication gets us where we need to be is generally okay by us.
Fantastic. And let's see. What should patients understand about medication adherence, even if their blood pressure looks good later? Like if they get home and they're taking metoprolol or some other kind of beta blocker and their blood pressure is really good, does that mean they don't need it anymore?
Yeah, no, it means it's good because they're taking the medicine.
Yeah, because it's working, right?
Yeah, and we see this in other areas too. The general advice I would give, I think, is don't make any changes to your medications on your own without discussing it with your doctor. I mean, that's not to say that the doctor is the ultimate decider or gets to say what medications you do and don't take, but it is crucially important that they know what medications you're taking, because that will inform the decisions. So the decisions are made jointly, of course, but if your doctor thinks you're taking lisinopril and metoprolol and you're not, and then you come in and your blood pressure is 185, that sends us down a different road than not taking any medications and a blood pressure is high. So making sure everyone on the team is on the same page and has the same information is the most important bit. So blood pressure is hard. Blood pressure is dynamic. And by that, I mean, it can be one number 1 minute and 5 minutes later, it can be very different. I recommend to patients after a stroke that they keep track of their blood pressure on a schedule. So ideally a couple of times a day at roughly the same time of day and roughly in the same scenario regarding their medications, if they take it before the medicine, if they take it after the medicine. And then when you go to the doctor, you can bring a notebook and you can say, over the last month, here are my blood pressures.
Right.
And that gives a much more complete picture of how our blood pressure control is than I took it at the pharmacy 2 weeks ago, it was fine. And now I'm in the office and it's not fine. Well, so which one?
But is it fine every day on a regular
Right.
basis? And which number might be the unusual one?
Correct.
Right? Which
So
one
what do
might
we
not be
react to?
accurate?
Yeah.
And then if someone does suddenly stop taking their medications, I know with beta blockers, people can experience what's called rebound hypertension,
Yeah.
right?
Yeah, and rebound tachycardia also. So
Yeah.
it's important and it's hard. It's much harder now than it used to be to get a hold of the doctor, to get a hold of the pharmacy, to get the medications refilled. It's just a very complicated system. Unfortunately, most of the things that we do now are rife with complexity and it can be a challenge. And everyone wants the best outcome for the care of the patient. And we just want to make sure that we're doing our best to stay in communication and keep everyone on the same page so that we know what's going on.
I will say, I do prefer sending a MyChart message to calling on if that's an option, because that way you don't have to wait on hold for an hour to not actually speak
for
to a doctor.
non-urgent things, electronic messaging like MyChart is preferable probably to everyone. I think it's easier for the patient for the reason you say you don't have to fight through the phone trees. It's easier for the physician because they can get to the message when they have a minute.
Right. And them specifically, and it not get hopefully translated to them through somebody writing down your message from the phone.
Correct.
And then, but especially in this case where I feel like I've had so many patients ask me about, well, can I just stop taking my blood pressure medicine? That's a really good thing to send as a MyChart message and say, hey, I would like to if I can. How can I do this safely? And then sometimes there's like a titration order that can be put in. And that's something that can be done without necessarily going in for a doctor's visit.
Sure.
And so that would be a really good example of having that communication without necessarily, having to schedule something or do it on your own.
And it gives an opportunity to discuss the overall plan. Why do you not want to take amlodipine at this dose? And there may be reactions to medications that really should drive a change in the plan.
Yeah.
And so communication is a two-way street, right? So it allows, I started lisinopril and now I have this uncontrolled cough. Well, that's a side effect of lisinopril, and then we should change lisinopril to something else versus just, I don't like this medicine. It doesn't make me feel good. I'm going to stop it. So
Or I've got to suffer through because this is the only
the doctor
answer.
told me to take lisinopril, and I'm going to, so
But we're trying to fix a problem, not create new problems,
correct.
right?
And
So,
and again, especially with blood pressure, oftentimes it's an issue of which side effects are the most manageable
yeah.
and which medications work. And it will be different from person A to person B to person C. So unfortunately, it's not as easy as everyone should try metoprolol first. Everyone should try hydrochlorothiazide second. It doesn't really work that way. And so everyone is individual, and we try our best to find the right plan for each person.
Yeah. And that's reassuring because, everybody wants to believe they're special.
Everybody is special.
And they are special. So if you get anything from Dr. Eckerle today, it is he believes every patient is special.
That's correct.
Yes. And we were talking about personalization and follow-up. Why is it important for patients to have regular medication reviews after a stroke, even if they're not having these side effects, like maybe annual follow-up with their primary care provider?
Yeah, I think it's just good practice, firstly, that medications be reviewed on a regular basis. It gives a chance to ask questions about, are we having difficulty getting it filled? Is it too expensive? Are you having side effects? Are we taking it at the right time of day? There are these different things. And then with stroke, there are some medications that we use in a time-limited fashion. So certain medications that I might start in the hospital with an instruction to stop at some time point in the future, you'd be surprised, or maybe you wouldn't, how often those medications get continued. And
Yeah.
that's not for lack of caring or lack of trying. It's just a communication issue.
Yeah.
And so having a way to touch base and make sure, okay, we wanted to be on aspirin and clopidogrel for 21 days, making sure we stopped the clopidogrel when we were wanting to stop it and things like that. It's in outpatient medicine, one of the most important things is making sure that we're taking the correct medicines at the correct doses at the correct times for the correct reasons.
Exactly. And what role can caregivers play in helping patients stay consistent with their medication plan?
Yeah, so lots of ways. One, helping manage all the bottles and schedules at home, whether that be with a pill box or with a phone alarm or a combination. That's helpful. Coming with patients to visits is super helpful because more ears at a time is going to increase the likelihood that everyone's on the same page with the plan. Doctor's visits are sometimes quick, and sometimes there are lots of questions, and then the doctor comes in and the questions slip away.
They forget what they were going to ask.
Yeah. And so having somebody there with you to keep track of what questions you wanted to ask, to have a second set of ears on listening for the plan, and helping carry out that plan and implement it at home, I think is super helpful.
And I think it's important to point out things like um, about half of people who experience stroke have their memory impacted,
Yep.
whether that's a long ongoing problem or if it's just in the short term. And so having a second person there to remember, how are we doing at home, and pick up on things that that person, the stroke survivor, may not even be able to recognize on
Yes.
their own, like cognitive changes or visual changes. So having that family member or someone who lives with them come in and participate in that and share what they're seeing, as well as ask questions and help write down the answers,
Yes,
can
absolutely.
be really helpful.
That stroke follow-up visit is critically important, partly for the medication piece, but also because two big things happen between when you leave the hospital, maybe two, sometimes one, sometimes two, and then when you come to follow up. One, you go home, and things are different at home than in the hospital. And the other is that you might go to rehab. And so how you feel and how you look and how you're doing on the day of discharge in the hospital is likely to be very different than how you feel, how you look, and how you're doing 6 weeks, 3 months, 6 months later. And almost inevitably, there are issues that come up at home that weren't foreseen by patients or families or doctors or nurses that need to be addressed. And getting a chance to touch base after we've been home, and if there are new symptoms, different symptoms that weren't considered while we were in the hospital, that's an opportunity to address those things.
Yeah. I know I've had quite a few people say that they pass their physical therapy assessment in the hospital.
Yeah.
Then they get home and they're like, well, why am I having trouble with my balance?
Right.
And I passed all these tests, but it wasn't in their home environment
Right.
to really see, what was required of them to do their daily activities.
Correct. You're not in your home environment. You're not being asked to do as much
Yeah.
independently in the hospital. There are people bringing you your medicines. There are people bringing you food most of the time. And you're not up on your feet as much in the hospital. You get up with the physical therapist, but passing therapy, meaning you don't need acute rehab, is not the same as you have no symptoms, right? And so there are stairs at home. There aren't very many stairs in the hospital unless you seek them out. There are slippery surfaces at home that aren't in the hospital. So it's super important that we get an opportunity to see how it goes. And that's one of the reasons we don't want to follow up in 1 week or 2 weeks after a stroke. Generally, we want to have some time, because this question comes up too. People leave the hospital after a stroke and want to follow up the next week.
Mm-hmm.
And while we would love to see everyone every week, it gives us more information to know how things have been going over 6 weeks or 8 weeks at home, to then be able to address those concerns in the clinic.
Well, that's awesome. What's one thing you wish every stroke survivor and their family knew?
I think the most important thing is that stroke is very recoverable. I tell patients that stroke recovery can continue for up to 6 months, sometimes even longer after a stroke, and that the strongest predictor of good recovery after a stroke is early and intensive rehabilitation. So the tests that I order and the medications that we start and all of those things that we think are very important for stroke prevention are for prevention, and the recovery piece is about rehab. And so I am always encouraging patients to be as proactive and active as they can be, to push for as much therapy as they can get and to work hard. And people are surprised how much better they can get. And that's, I think, critically important, especially on those scary first couple of days.
Yeah.
Because it is something that can get better, and it often gets a lot better. And
Yeah.
we want people to have that hope and to work hard and push to get better.
Yeah. The more we learn about neuroplasticity, the more
Yeah.
we learn people can recover and
And
regain their function.
And there are cool new strategies coming out recently, and more to come, I'm sure, of new ways to augment that process and keep working on getting better. So it's an exciting area of research, and just really encourage people to remain as positive as we can in the face of what is certainly a challenge.
Yeah, definitely. So if someone listening is feeling overwhelmed by all the pills they have to take, what's your best advice for staying encouraged and on track with this?
Yeah, my advice for that is to try to keep in mind the why, right? Why do you want to get better? Why are you taking the medications? Sure, the doctor said to take them is a reason. It's probably not the most compelling reason to me. Being able to get back on the golf course would be a really compelling reason. Being able to help take care of grandkids would be a really compelling reason.
Or your pets.
Or pets, or keeping in mind why we want to get better and why we want to stay better is going to help frame those questions around which medication should I take? How do I need to do this? What's the best way to stay healthy? Because it's about quality of life, and it's about improving your experience on the planet, right? And so if you can keep in mind your why, it makes it, I think, easier to manage and to stay on top of the tools that we have available to help us achieve that why.
Excellent. Well, I agree. That is so beautiful. And I hope that you have found this encouraging and enlightening as to the process of how medications are chosen and why they matter. And if you have learned something in this episode, feel free to leave a comment. If you're watching on YouTube or listening on any of the audio platforms, let us know if you have any additional questions, and make sure you're subscribed so you'll be notified for the next episode. And I'll see you there.